Hi Nitin. Everything sorted out? Hi Shilpa.
Hello, sir. Nice to see you.
तू क्या
हेलो
एकदम
सर।
पूरे स्टार ट्रेक में घूम रही है ऐसे लग
बस वो पीछे वो लगा लिया.
रहा है.
गुड इवनिंग मैम, गुड इवनिंग सर।
Good evening.
हाय हाय नितिन.
देयर वाज सम स्मॉल टेक्निकल डिफिकल्टी, वी सॉर्टेड इट आउट।
अच्छा अच्छा.
Will you
क्या
be able
दिल्ली
to?
गई थी?
What technical difficulty?
द पर्सन हु इज स्टार्टिंग शी हैड सम डिफिकल्टी बट नाउ इट्स टेकन केयर।
Because
अच्छा.
the username password we have to take from IAPS, na? So we thought
नो,
that's
one
the
of
issue.
द पर्सन हु was supposed to start, he started the meeting right now.
अच्छा अच्छा. चल मैं चेक कर लेता हूँ शेयर स्क्रीन करके.
ठीक है सर. And
शेयरिंग इज
Nitin,
नॉट टर्न्ड ऑन. यू हैव टू मेक अस
हाँ ये,
co-host.
या
जिन जिन का
I,
प्रेजेंटेशन है उनको co-host बना के ही रखो पहले. नहीं तो
hmm.
वहां पे बहुत टाइम पास होता है.
Or there is one option of multiple sharing allowed, like and then people share multiple and then it becomes a problem if they don't know.
no, I can take care of the Zoom part, ma'am. Make accepting the this one. And
ടെക്നോളജി പ്രത്യേകിച്ചും വിളിച്ചപ്പോൾ അവർ എല്ലാ സമയത്തും മീറ്റിംഗ് ഒക്കെ ഒപ്പിക്കണം
Yeah,
കാര്യങ്ങൾ.
and record also.
अच्छा पहले अभी तक वो शेयरिंग नॉट
Host
अलाउड
नहीं
दिखा रहा है.
बनाया. अभी hello, Tejaswini is the host अभी. She's not yet.
Dr. Navya, hi. Can you make me admin or this one so that I can allow sharing?
Tejaswini has the host.
Hello, good evening, ma'am.
Good evening. Navya can't do anything because Navya is not the host. Like Navya is muted also. Navya, we can't hear you. So, Tejaswini, are you there?
Yes, ma'am. Just a
So,
minute.
please make Dr. Nitin the host or co-host, whatever is possible.
Yes, ma'am.
Yes. Yeah. And make Navya also co-host. Navya, you'll be managing something.
Yes, ma'am. Could I just check if I'm able to upload my presentation, ma'am?
And Dr. Dasmeet also.
Navya is co-host now.
Yeah. And make Dr. Dasmeet also co-host. Yeah. So once Dr. Dasmeet's presentation finishes, then you
You are
can shift
co-host
that
now.
co-host
Okay,
to
now let
someone
me
else.
check.
At a time, we'll keep only 3.
हाँ ठीक है.
Ma'am, can I check if my presentation is
Sir wanted to check first. Let's sir check, then you
Yeah,
can.
I'm just checking.
Yeah. He's
Okay,
already
can you
shared.
see my screen?
Yeah, yeah.
Yep.
Yes, sir.
No?
All is
So,
fine.
all right, fine. So we are good to go. So I'll
Yes,
stop sharing.
yes, sir.
तो हमारा सब ठीक है.
Navya,
Okay.
you can share yours.
Thank you.
नावे check कर लो.
Is it visible, ma'am?
Yep, perfect.
Thanks.
अच्छा स्पेक्ट्रम डिस्कस हो जाएगा because there's surgical, ours is non-surgical because we haven't yet reached the stage of surgery. अच्छा good discussion should happen. So let me introduce Dr. Divya इधर आ जाओ. So we are sitting in Jahangir only because there was no time. I just finished a masculinizing genitoplasty. उसके बाद डायरेक्टली मैं फिर ओपीडी आ गया. तो दिव्या is going to be presenting. She is our DNB pediatric resident.
Good evening, all.
Good evening.
Hi,
He's
Dr.
very
Divya.
good. Dr. Vibha Bapna, who's our medical oncologist, pediatric medical oncologist. She'll be joining. It's told her to join around 7 o'clock. So she should be coming in soon.
We'll wait for
So any kind of discussion which involves the pediatric medical oncology also, that can also be done.
Dr.
Generally, how
Satish,
many people attend? अभी तो 14 ही दिख रहे हैं.
I think we'll get up to 60, 70. Dr. Satish, you want to check your slides? You have to make him co-host.
शव ये अपना सर्जरी रेजिडेंट है उसको भेज दिया था मैंने
Ma'am, this is Dr. Madhulika,
Dr.
ma'am.
Madhulika will be presenting. She's our pediatric hemato-oncology registrar here at our institute. So she's going to be presenting the case. And we have our pathologist, Dr. Vidya, also joining us.
Do you want to check your slides or it's fine? Just
We have already sent the slides to Dr. Nitin, ma'am. I think, yeah, she can check it. Madhulika, you can just go ahead and share your screen and check your presentation. Yes, yeah,
yes.
that's coming on.
Good evening, Partha sir. Very nice to see you.
Good evening. Nice to see you too. Good
Hi
evening, Rasmi.
Partha,
Hi. Good to see you.
good to see you.
Ma'am, you're able to see the slides, ma'am?
Yes, they are nicely visible.
Kolkata.
Thank you, ma'am.
Clear slides. Anybody
Fantastic.
else wants to
Paint.
check? We've checked 3 presentations. 2 more are left. One is Nitin's only. Nitin, do you see any other participant who has joined and has to present?
Shilpa, your voice is going in between.
I know something is wrong with my mic since 2 days. It's better now?
गला ही खराब है.
No, gala nahi, my laptop mic.
Oh.
Since 2 days I'm hearing this thing out your
So,
voice.
if you have a pod, that would be better.
Okay, I'll
That
get it.
bypasses this because that will
Yeah.
go via Bluetooth.
Yeah, I'll do that.
Is my slides visible, ma'am?
Yes, visible.
Yep.
Ma'am, we have our team here from KMC Manipal. Just wanted to our HOD, Dr. Santosh Prabhu, sir, and Dr. Vasudev, but he's the HOD of Pediatric Oncology. Dr. Umesh is the head of Radiation Oncology. And we have Dr. Priya from Radiology and Dr. Swati Prabhu from Pathology.
Wonderful. That's a full MDT. Welcome, everyone.
Excellent.
Yeah.
Wonderful. Welcome.
So you can begin the recording and then begin dot on time.
Yeah, just a couple of more minutes. And this is
Is
the
the
proposed schedule, ma'am. Dr. Divya and Asmit sir going first, followed by Dr. Tish M from Rela Institute, and then followed by Dr. Navya and Dr. Tejaswini. They have mostly similar case, so we can do the discussion
CCSP.
after both, yes. And then followed by Dr. M. Fazal from Jipmar.
Has he joined? I didn't see him in the participants yet. If you have his phone number, you can give him a call.
Yeah, I'll.
Is my audio okay now?
Yeah, much better.
Thank you.
Although there's some kind of a shoe sound. AC, Pankha.
That's the fan, yeah. So Yeti is very sharp. Yeti mic. I think we can begin, Nitin. You can welcome everyone and start.
Yeah, good evening, everyone. On behalf of APSO, with the chairperson, Madam, and our APSO secretary is still down, but she will be probably joining in just a while. I'm Dr. Nitin. I'm the EC member of APSO. And we have members from KMC Manipal, and welcome everyone to this tumor board. It's conducted like after a long time. Previously also APSO tumor board have been held, but yeah. So I request everyone to mute their mics if during the presentations. Also, we will stick to the timeline. The presentation first minute is 15 minutes. Rest of the presentation will be around 11 minutes. And yeah, and then without much delay, I think I'll hand over to our chairperson, Dr. Shilpa Sharma, to take over.
So I would invite Dr. Dasmeet Singh and team to please begin with the first presentation. You can share your screen. I hope you've started recording, Nitin.
It's recording.
Yeah, for those who miss it.
I'll request Divya to present. As I said earlier, she's our pediatric houseman, second year now. So she's going to be presenting the case.
Good evening, everyone, esteemed panelists and respected sirs. Today, I'll be presenting a case of uncommon presentation of Wilms tumor. This started with when a 2-year-old male child. Is my slides visible? Yeah. So, a 2-year-old male child, first by birth order, born out of non-consanguineous marriage.
Unmute yourself, Divya.
Yeah. So, when a 2-year-old male child, first by birth order, born out of non-consanguineous.
Somebody is muting.
Yeah, Tejaswini, are you pressing mute all? Do not do that because the presenter needs to speak. When she starts speaking, just mute the people who are talking extra. Otherwise, don't.
Yes, ma'am. No,
Yeah.
I did not do anything. It's just happening on its own.
Automatic. Okay.
Yeah.
All right. Fine then.
So, with complaints of blood and urine, sudden onset 2 to 3 episodes with total urine containing blood with increased frequency of urine, and there was fever low grade 6 to 8 hourly not associated with rash since 1 day. Infectious causes was ruled out as there was no dysuria or pain in abdomen. There was no history of trauma, bleeding, drug or food intake. There was no history of significant weight loss, swelling or mass or edema over the body. Past history was not significant, with no similar illness in the family. The child was born through natural conception, full term, normal vaginal delivery male with birth weight of 3.4 kgs, with postnatal period unsignificant. Developmentally, the child was appropriate for age with immunization completed till date. On examination, there was pallor present. The BP was noted on a higher centile, which is 90th centile, the recordings of 128 by 80. Abdomen was soft, no tenderness, organomegaly, or mass was appreciated. On anthropometry, the child was within normal range. When blood investigations were done, it was found that the child had low HB, suggesting microcytic anemia, which was confirmed with low ferritin level. Later, coagulation parameters were done, which suggested of elevated INR and prolonged prothrombin time. USG abdomen was done, suggesting of a solid mass involving the right upper pole of the kidney, and left kidney was absolutely normal. The component was mixed solid plus cystic. Further, a CT abdomen was done, suggesting a heterogeneously enhancing mass in the right kidney at upper and middle pole with moderate dilation of the pelvic ileal system. There was no thrombus in the renal vein or IVC, but the tumor was invading the regional lymph nodes. Further on, the CECT test was done to look for metastasis, and it was confirmed that there were 3 to 4 ground glass nodular lesions in the left lower lobe segment of the lung, which were more than 5 millimeter in diameter. The significance of this is the plan of action would be planned based on the size of the nodules in the lungs. More than 3 to 5 mm are considered as lung metastasis, as in our case, which was further treated with preoperative chemotherapy started with actinomycin, vincristine, and doxorubicin. Whereas, if the nodules would have been 1 to 2 mm, they would have been considered as localized tumors, and treatment would have been preoperative actinomycin, vincristine only for 4 weeks. So, in our case, this was a patient of suspected metastasis where the size of the nodules were more than 5 mm. We went on ahead with preoperative actinomycin, vincristine, and doxorubicin therapy for 6 weeks, planned with radiological reassessment after 6 weeks and a surgery later. A renal biopsy was done to confirm the diagnosis, which suggested a poorly differentiated malignant tumor, biphasic blastomal and mesenchymal differentiation with no anaplasia. In our case, as the child was more than 6 months but less than 7 years of age, with unilateral renal involvement, a solid and cystic mixed tumor component with no calcification and metastasis primarily in the lung, a biopsy was carried out. Biopsy would have been recommended if the child would have been more than 10 years of age or uncertain renal origin with metastasis at other sites involving the bones, CNS, or pulmonary under 2 years of age, and elevated urinary catecholamines or hypercalcemia, which in our case was found normal. Further, the time frame of diagnostic workup is very important. First, we'll do a diagnostic workup right at the presentation, which is as day 0. Later, at 4 weeks after the preoperative chemotherapy, and later after 6 weeks of chemotherapy to plan a surgical approach. So summary, when a 2-year-old male child with complaints of fever and hematuria was admitted under Dr. Dasmeet Singh in Jahangir Hospital, Pune, after ruling out infectious causes, CT abdomen and CECT chest was done, suggestive of localized solid plus cystic component mass in the right upper pole of kidney with metastasis in the lung. A core needle biopsy was then carried out under the USG guidance. Diagnosis of unilateral Wilms tumor was established. Under the guidance of Dr. Vibha Bafna ma'am, preoperative chemotherapy started with actinomycin, vincristine and doxorubicin. Childhood renal tumors are relatively uncommon, but amongst them, 80 to 90% are Wilms tumor and the rest of them are non-Wilms tumors. The SIOP-RTSG is a guideline that suggests an umbrella protocol to continue the collaboration in diagnosis and treatment of the childhood renal tumors. So, stages of Wilms tumor. Stage 1 is when the tumor is limited to the kidney and is completely resected with no microscopic residual margin after surgery. Stage 2 is when the tumor extends beyond the kidney but is completely resected with residual microscopic margin. Stage 3 is non-hematogenous metastasis confined to the abdomen. Stage 4 is presence of hematogenous metastasis or metastasis to distant lymph node as seen in our patient. Stage 5 is bilateral renal involvement at the time of diagnosis. This patient was evaluated for dysmorphism and the syndromes were suspected, but as there were no dysmorphism, the syndromes were ruled out, which are associated with Wilms tumor. So, metastatic pre-op chemotherapy was started in this patient with actinomycin, vincristine, and doxorubicin, doses adjusted according to the weight band, with a plan of vincristine for 6 weeks, actinomycin every 3rd week, and doxorubicin was started at the 1st week. In surgical guidelines, further we have a plan of doing a nephrectomy with long transverse incision. Every lesion would be excised or biopsied and the position would be marked. The plan is to remove the tumor with the adipose capsule and Zirota's fascia in a monoblock resection and all the invading structures surrounding the tumor. The tumor bed would then be marked with titanium clips to guide the future radiotherapy. A nephron sparing surgery would be planned if the tumor is restricted to only one pole of the kidney. The volume of the tumor after the pre-op chemotherapy is less than 300 ml. There is no preoperative rupture, there is no invasion of the surrounding organs, and no thrombus in the renal vein. And if there is a possibility of sparing at least 66% of the renal tissue after the tumor resection to avoid any hyperperfusion. Metastatictomy would be done for this patient if after the pre-op chemotherapy, if there are 6 accessible nodules and more than 5 lesions in the lung nodules, metastatictomy would be done in the same setting as the nephrectomy. If the liver is involved, isolated liver mets would be excised via a wedge liver resection. Based on the surgical post-op, we would be classifying the tumor according to the histology in low risk, intermediate and high risk. Low risk suggestive of necrosis and mesoplastic nephroma, intermediate where a non-anaplastic nephroma would be seen, and high risk when a nephroblastoma with diffuse anaplasia or clear cell sarcoma or rhabdoid tumor of the kidney would be seen. Accordingly, we would then reclassify the patient now for the second time and then the post-op chemotherapy would be initiated. So the plan would be to grade the patient into stage 1, stage 2 and stage 3 depending on the stages of the Wilms tumor and now reclassify the patient based on the histology into low risk where only necrosis would be present, intermediate where there would be stromal and epithelial mesenchymal component and high risk with blastomal and diffuse anaplasia. Stage 1 with low risk would require no further management. If intermediate mesenchymal and epithelial component would be present in the post-op histology specimen, we would give a chemotherapy of vincristine for 4 weeks and actinomycin at the second week single dose. If a high risk tumor is found or high risk histology is found, the post op chemotherapy would extend for 27 weeks, with vincristine for the first 8 weeks, then every 2 weekly, actinomycin every third weekly, and doxorubicin every 6 weekly would be given for this patient with a total duration of more than 27 weeks. In stage 2 and stage 3, with low and intermediate risk histology, we would give aggressive chemotherapy with actinomycin and vincristine. Again, the same protocol with vincristine for first 8 weeks, every 2 weekly then, and actinomycin every third weekly. In high risk histology, 2 cycles of chemotherapy, each every third weekly would be started. The first cycle would be of cyclophosphamide and doxorubicin at weeks 1, 7, 13, 19, 25, and 31. The second would be etoposide and carboplatin at week 4, 10, 16, 22, and 28. So alternate every 3 weekly with a total duration of 34 weeks. Post-op, the patient would be now reassessed for the chest nodule size. If the nodule is less than 3 mm, the post-op chemotherapy would be managed further and would be changed. If there are no nodules in the repeat CECT, we would then just observe the patient, plan a CECT every 8 to 12 weeks for the first 2 years from the diagnosis period. If there are persisting nodules, we'll look for the viability. If there is a necrotic tumor, we would give the chemotherapy based on the localized stage that we got from the surgical histology. And if there is diffuse anaplasia or viable tumor, we start aggressive chemotherapy with actinomycin, vincristine, and doxorubicin, cumulative dose of 250, and reassess the patient at week 10. If the size is increasing or there is a viable tumor, then we'll give a aggressive chemotherapy with AV and vincristine that will give a aggressive dose. Post-op chemotherapy, if the nodule is more than 3 mm, will classify into A, B, C, and D. So A, if the metastasis nodule is absent or completely removed by the surgeon, we would grade the histology. If the nodule is more than 3 but less than 5, we would give a regimen for actinomycin, vincristine, and doxorubicin for 27 weeks. If more than 5, a aggressive regimen with AVD would be given for 27 weeks, along with radiotherapy that would be considered. If there is complete surgical removal of only non-malignant tissue, we would go for flank of abdominal radiotherapy and no pulmonary irradiation at this stage. If there is metastasis but more than 3 mm at diagnosis and the nodules were incompletely removed, we'll basically see for viability. If the tumor is viable and not unresectable, so we would give a aggressive chemotherapy of actinomycin, vincristine, and doxorubicin, cumulative dose of 250, and plan for a lung radiotherapy. In stage C, when the tumor is viable, the tumor is active, and the nodes are not resective, the histology suggestive of high grade, we would give a 4-drug regimen for a total of 34 weeks. And a lung radiotherapy along with the abdominal radiotherapy flank would be planned. The patient would be reassessed post radiotherapy at 10 weeks. A repeat CCT chest and abdomen would be done. So the radiotherapy guidelines are: first, for abdominal disease, usually we give the abdominal radiotherapy in a fraction of 14 fractions for intermediate and high risk histology, and for low risk we usually go for 7 to 8 fractions. For pulmonary and other metastatic sites, the lung irradiation is usually suggested when the tumors post-op are either unresectable or there is still a viable tumor even after the post-op chemotherapy. So after that, we would give a chemotherapy in 8 fractions. A dose of 12 to 15 gray is usually given. In liver, if there is incomplete resection, again a setting of 8 fractions radiotherapy would be considered. Whole brain irradiation usually is considered in 10 fractions when a brain involvement is seen. And for other mets of bone, we would usually consider a 17 fractions with a high dose of 30 gray radiotherapy. So the take home messages from this presentation would be: Wilms tumor can have a basic symptoms of fever and hematuria and can present without a swelling and mass, and finding it as an incidental finding on a radiological investigation. So every patient should have a radiological screening of abdomen in symptomatic patients is very important. Timely chemotherapy and surgical intervention can improve the prognosis of Wilms tumor patient. CCT chest to be done in all cases to look for lung nodules so that we can classify the patient accordingly pre-op, do a surgical intervention, post-op reclassify the patient, and then plan a post-op chemotherapy. Thank you so much.
Sure.
Thank you, Divya. That was an excellent presentation. Dasmit sir, do you want Vibha to say something now?
Yeah. Dr. Vibha, have you joined?
Yes. Uh,
Yeah, some comments from
Good
you.
evening,
So,
everyone.
Yeah,
so
good evening.
before Vibha said,
Good
so let
evening.
me tell you that when I had admitted the patient, I had just asked for an X-ray chest, and then Vibha came into the picture. I asked her to have a look at the patient. She's like, no, the X-ray chest is of no use. Just get a CT done. That's the recommendation of today. So, Vibha, over to you.
Yes. So basically, it was a difficult thing to sedate this child for CCD abdomen. So I took that chance. I said, please do the HRCT test. So that is a standard of care now. In PSYOP 1, they used to say that you may not do CT chest, but UK still went on to do CCT chest. But now the latest umbrella protocol which Divya has mentioned, we are supposed to do CT chest because now I suppose availability is universal. So here we too are surprised because otherwise on imaging the child was looking like stage 1, very clear cut patient, except that he had probably the tumor involvement in his pelvis, and so his presentation was with hematuria. So that clinical presentation is also very rare. I think this may be just 1 or 2 times that I've seen a child presenting with hematuria. Most of the children present with abdominal lumps. That's the commonest presentation. And so that was again anything odd. But when I found these small lung nodules, then we decided that we need to go ahead with the higher chemotherapy. As we have said that we would have, even under the protocol, we could have started everything without doing a biopsy. But that is my personal thing, and Dalpreet myself, we've been working together. So we've always gone ahead with biopsy. So again, countries differ over there. There are most of the European country will go ahead with not doing a biopsy in a very classical presentation that she said. The child, typical radiological features, the typical age, everything. You may not do a biopsy, give pre-op chemotherapy, go for a reassess, go for a nephrectomy, and then go on to classify the child. The complex classification which Divya has mentioned. But personally, I like to do a biopsy for whatever reasons, just to be on the safer side that we are not dealing with something else. So as expected, the biopsy has revealed a Wilms tumor only. And let's see, probably we will get back to all of you when, on the further course of this child, once the nephrectomy is done.
So you have started the chemotherapy?
Yes, ma'am. Yeah, we have started the chemotherapy. We have given him the first dose of AVD. And according to the protocol, we will be giving weekly vincristines, and alternate weeks we'll give dactynomycin, and we'll give 2 doses of doxorubicin. So basically, doxorubicin, there is always a capping dose. We never exceed a cumulative dose of 300 for the reason that, we should not be causing cardiotoxicity. So it has been proven that any cumulative dose of doxo above 300 may cause long-term cardiac toxicity, acute and chronic. So the entire thing about Wilms has got such an excellent prognosis. So the world of oncology is always trying to see where we can decrease treatment. So in fact, in the PSYOP 1 protocol, in the intermediate risk, they tried treating patients with or without doxo. So in the umbrella protocol, now they have said that the intermediate risk, localized tumor, you may not give doxo. So we are trying to come down on treatment because when the outcomes are so nice, it is always a worry that you are over-treated. So the thing in Wilms tumor is to give less and less of chemotherapy and decrease the indications for giving radiation also. So that's the philosophy basically in Wilms tumor.
But here it becomes stage 4 the moment there are lung metastases up to 5 millimeter.
Yes. Absolutely. But then also, ma'am, the prognosis doesn't come down. Wilms has such a good prognosis. And in my opinion, these are actually, if it was PSYOP 1, I would have called them CT-only mets. So when there is nothing on the X-ray chest, but the CT has lung nodules, because CT is a more sensitive and it picks up these small nodules also. So in my opinion, I have a strong feeling that these will disappear when we do the repeat chest CT at 6 weeks. So once they disappear, then they come back to the local staging. And all the chemo goes according to the local staging. If they disappear radiologically.
Clinically, this means
if they don't disappear, then we are in a soup.
Dasmeet sir, clinically, how is the tumor? Is it operable? Is it mobile?
No, it's I could have operated it, but it's not recommended to operate because there's already metastasis. So, so it's better to first give anti-chemotherapy, see what
Yeah,
is happening to the nodules,
control the metastasis. Absolutely,
control the
absolutely. I
metastasis
totally
first,
agree there.
and after that only then tackle the primary.
Yes, yes. Actually, there the world is divided into two. So the entire Europe believes in the SIOP, basically the International Society of Pediatric Oncology, always goes with chemo first. Whereas the Americas, the North Americas, they always want to do upfront nephrectomy and then carry on. I think Dr. Mishra
Yeah,
wants to
both
speak.
school of
Hello,
thoughts are
ma'am.
there.
How are you?
Yeah. Kanishka sir?
Both school of thought.
Yeah, she's raised her hand. Her turn will come. Kanishka sir, your
Yeah,
comments.
I think she has discussed the
Very nice.
algorithm extensively, and they are somewhere right in the beginning of it. So we will have to wait and see which route it takes. And there are so many variables in this particular case: the mass, the
Absolutely.
metastasis, the age of the child, and also it was good going through the algorithm, very extensive algorithm, but it was good recapitulating that. So we are still in the very beginning of the management. Yes.
Yeah, Shalini?
Yes.
Right.
I missed the initial part, but I've understood what it is. So very nicely, all the details have been discussed, and Dr. Vibha also has mentioned all the both the approaches. So what I liked was Dr. Dasmeet Singh sir mentioned that I just ordered a chest X-ray, and the pediatric oncologist came and said, no, we have to do a CT chest. So I just want to emphasize, even though we think Wilms tumor is easy, we can manage. We as surgeons, we have done it. We've all done it. We've given the chemo. We've done everything, but now the protocols have become so intricate, so subdivided, so sub specialized, trying to minimize the long term complications and also improving the outcomes, that we must involve the pediatric oncologist. And there are plenty of them there now. Earlier they were not there, so we had to do everything. So you must involve them from the beginning. That's very good, actually. I have seen in front of my own eyes the outcomes improving so much when I was doing everything and when the pediatric oncologists have taken over. So, and one more thing is about the lung metastatectomy. She told they don't disappear at the time of surgery at 6 weeks. We usually don't do that. But SAP umbrella says that if you don't do that, then you have to take it as positive and you have to step up the chemo and then, everything, and you have to give radiation and everything.
Yes.
So if it did
Yes.
disappear, if it is operable, we have to try and attempt. Again, that is challenging. A small baby, big, large renal tumor, and you're going to operate on the abdomen and then again on the lung. So it may not be feasible to do it at the same time, but probably you can give 1 or 2 week chemo after 2 weeks gap and then do the lung metastasis.
Yes.
In fact,
Yes,
one
absolutely.
one
That can
group
be done.
takes
Yes,
a
ma'am.
thoraco-abdominal incision only, so where you tackle both.
No, that could also be if
Oh
suppose
my
the
goodness.
Wilms
I
tumor
wouldn't do
requires
it. I
thoracoabdominal, you
wouldn't do
can
it.
do it. You can do it. If you have the good
It
Yes.
can be
support,
done,
you can
but
do it.
some I would be disinclined to do it. Because the morbidity increases tremendously.
That's what I was trying to say. That's
Yes.
why we do it in a
Absolutely.
staged manner, because our
Absolutely.
children are malnourished. They may not be able to handle that bigger
Yes.
surgery, and then we don't want to lose a child just because of some surgical complications.
Yeah.
No, with Wilms having such an excellent prognosis. So, yeah, definitely. Definitely. So, in my experience, I don't think we have come to that stage. Most of the times, the Mets would disappear on the CT. I mean, that's
Right.
my take on it. So, I'm just hoping, let's see what happens to this child.
Dr. Satish?
Just wanted to make a small point about the umbrella protocol. Actually, if you go through it, the current guidelines actually recommend MRI as the first modality of investigation. If
For the abdomen. Yes. Yeah,
this for the
you're
abdomen.
correct.
So,
And that is purely for
and
the
the soft
reason
tissue
of
definition that
avoiding
you
too
would get
much
with an
radiation.
MRI is really great. So that is a point that I wanted to make. So CT chest is definitely on. Nobody gets only a chest X-ray anymore. So.
But we have to be careful where we get the MRI done. Today only one of my follow-up patient came, a neonatal cholestasis, and she was told an MRCP, and she was scared because the child had gone into the suit for 7 hours with anesthesia and everything and came out so late. So it's
True, ma'am.
scary. If it is in the hospital, it's fine. But if
Hypothetical,
private
right?
setups, a
Not in a
little
private
baby,
setup. It's a
yeah,
very risky
it's
thing
very
to.
risky. So we have to be in
So,
our setups and plan what we can do best for the
so
child.
Umbrella says that MRI
Yes,
is desirable, but in our setup, it's very difficult
yes,
to do
yes.
MRI in the beginning.
Very
So
difficult. Agreed.
even if we do
Agreed.
CT, it's fine. If you do a good CT under sedation, it's quick and you can do the same day probably. I know in the government it may take longer time, but it's okay to do CT, but don't forget the chest. And
Yeah.
chest, all that is required is non-contrast. You don't need a contrast.
The only surprising thing which I found was that after, let's say, the surgery has been done, histopathology, reclassification, grading has been done, chemotherapy done. After that, every 8 to 12 weeks, a CT scan has been recommended. This
No,
I
no,
found it
no,
a
no.
bit,
I wanted to differ over there. No, no, we don't do CT chest so
yeah.
often. What we do is in the first year, what practically we do is we do X-ray chests. I mean, once we have decided, declared that the child has cleared his CT chest, maybe like 3 weeks after we have completed the therapy, we do a recheck of a CT chest, and then we keep following up with X-rays. So once in 3 months, we do X-rays and USG. Just we follow up with plain X-rays and USG abdomens. And then, of course, the nephrology people take over and look after the single kidney. So that follow-up is also very important. I want to make a point over there also. Once we are done, we hand over the patient to nephrologist and they look at, taking care of the single kidney. But we don't do CT test. I think I would differ over there.
Ma'am, there's a question for you in the chat box. Was the true cut biopsy USG guided?
Yeah.
Yes, ma'am.
It was
It
done
was
by an
done by the
interventional
interventional
radiologist.
radiologist.
Mm-hmm.
So it was totally USG guided.
And what
Thank you.
So
route?
nowadays,
What route was
absolutely
it?
blind procedures are.
What route
Posterior.
was
It was a posterior route. Yeah.
So
From the
I
renal
also want
angle.
to say that sometimes we send to the intervention radiologist, and maybe a junior person there may do it through anterior route who may not know. So I always send one a resident
Yeah,
along
yeah.
with the Wilms tumor test.
No, we
Yes,
don't
yes,
have
yes.
that
I think
problem
that's
at
a
all.
very valid point. That's a very valid point because that will upstage the tumor. We will
Quite,
immediately upstage the child if it is
yeah.
done by abdominal route.
Definitely.
Yeah.
It's to be taken as a spill, even though it's not. I mean,
Yes,
it may or
it's
may
taken
not
as
be,
a
but
spill.
yeah.
And in
Yeah,
the surgical guidelines, I wanted to mention one thing, and especially in this forum, that you have to, whether the surgeon feels that the lymph nodes are involved or not involved, but they have to come out with 6 and more lymph nodes. I think that is not been
7.
mentioned, but it's there in the older guidelines. That's very important because sometimes I suppose the practice was that if you feel that the lymph nodes are normal, then your fingers abnormal, then you bring them out. But I think the guidelines is that you have to come out with 6 lymph nodes
Yeah. Six stations
and
minimum.
more.
6 stations minimum.
Minimum. 6 is
It is
minimum, but
5
anything more would
stations,
be.
and if the pathologist can identify 7 nodes, then
That's
the
best.
chances of having positive is more.
Right.
Exactly. Yes, ma'am. Yes, that is very important. It's again for the staging.
Dr. Partha, are you there? Sir was the first one
Can
to
we go
join.
to the
Yeah, we can go to the next case now.
Yeah,
next?
please
Yeah.
do. I am
A
there,
lot
but
of
I don't have
interesting
anything to
other
comment
cases
on
also.
this.
Okay, sir. Thank you so much. So
Thank
we move
you.
on to the next case. Thank you so much, Divya and Dasmeet sir. It was a very nice presentation.
Yes.
Nitin,
Yeah,
can
we invite Dr. Satish and from the RELA team to proceed.
So Dr. Madhulika is presenting on our behalf. She is our pediatric hemato-oncology registrar, and Dr. Julius has joined us. Dr. Vidya Lakshmi, our pathologist, and Dr. Gauri Priya, they are also online.
welcome everybody. Very nice to have a board.
Ma'am, am I audible?
Yes, you're very clearly audible.
Good evening, everyone. Our case is a 3-year-old girl who presented as an incidentally detected right lumbar mass. She was evaluated outside at her native place. So imaging done outside was with an ultrasound abdomen, which reported a large lobulated lesion.
Your slides are not moving. Have you shared the right screen?
Yes, ma'am.
We just see one slide here.
Now, ma'am?
No, only one slide is visible. So just unshare and share the right window. Yeah,
Now,
now it's okay. Carry on.
Uh,
We,
1 second.
yeah.
Ma'am, is it visible now?
Yes, Madhulika, it's visible.
Ultrasound was done, which showed a large lobulated lesion of size 13 cross 6.5 in the right lumbar region, displacing the right kidney, likely a retroperitoneal tumor. A CT abdomen was done, which showed a large, well-defined lobulated lesion measuring 10.2 cross 9.2 cross 13.2 centimeter, noted in it with its epicenter in the right kidney and having a mass effect, possibly a Wilms tumor. So she underwent an ultrasound guided biopsy in January 2026, which the HPE report suggested tubules were lined by the columnar cells with high nuclear cytoplasmic ratio with crest of immature blastemal cells. So then she was referred to our hospital and she was started with a neoadjuvant chemotherapy according to the umbrella protocol with vincristine and actinomycin as a 4-week regimen. And she underwent a reassessment with CET abdomen, which showed a large enhancing solid mass of 9.4 cross 5.8 cross 6.5 centimeter, which showed a reduction compared to the previous CT. On the left side, we can see that there is a large heterogeneous lesion making a claw sign. And on the right side, there are coronal and sagittal images which show that the mass is arising from the upper and the interpole with the extension into the pelvis with the compression of the renal parenchyma. There were no calcification and no renal vein thrombosis. So she underwent a radical excision of the tumor along with the gyratosis fascia and the perinephric fat. Next, I will request our pathologist consultant, Dr. Vidya Lakshmi ma'am, to speak about the HPE.
Good evening. Thank you. I'll carry on from here. So here we can see the gross image, which is cut open of the radical nephrectomy specimen. So there was a residual viable tumor, which was involving the lower pole, and it was actually pushing the ureter downwards and displacing the hilum also and extending into the mid region and into the upper pole. Now, the tumor was extensively sampled, it was mapped sequentially, and multiple sections were taken from the ureter to look for the renal sinus because it was obliterated by the tumor, and from the hilar regions and for the margins as well. Next slide, please. We'll see the histopathology. So this is a microscopic image. Here we had a residual tumor which showed a classic triphasic Wilms. It had a predominantly stromal component which was more than 60% and followed by epithelial component which was around 10 to 20%, and blastemal component was about 10 to 15% in many of the areas. And in the inset, we can see the immunohistochemistry. WT1 showed variable staining diffusely in the tumor, and it was strong in the stromal component, and it had a variable staining in the epithelial component. And below is the image of PAX8, where we can find the epithelial component highlighted on PAX8. And viable tumor constituted about more than 70%. So next image. So in this, we found two focal areas which showed anaplasia. So we would like to discuss more about it. So this was one nodular area within the otherwise non-anaplastic Wilms tumor, which was about 2 to 3 mm. And this showed markedly pleomorphic large cells which had enlarged nucleus almost 3 times size. And it had hyperchromasia along with some bizarre forms and multinucleated forms. This was seen in the stromal component in one section. So the next slide, please. In these areas, we also found atypical large enlarged mitosis. So with this, it was taken as a focal anaplasia. P53 immunohistochemistry done was wild type in this particular area. Next slide, please. And this was another focus which showed anaplasia again. Here we found the anaplastic cells in both the epithelial and the stromal component. So in this again, there were large enlarged bizarre cells and multinucleated hyperchromatic cells. And multiple mitosis, which were atypical and enlarged, were also noted in this. Again, P53 was wild type in this. So in this tumor, after extensive sampling and examination, we had 2 areas which were focal, showing anaplasia. Let's move on to other slides. Now, there were other areas in the tumor where we found marked nuclear pleomorphism. So each picture is from multiple areas of the tumor. So we can find that within the epithelial and stromal component, there were markedly enlarged pleomorphic cells like what we saw previously. However, we could not find any atypical mitosis in these areas. Now, this was not any atypia related to previous chemotherapy. The changes were exceeding any chemotherapy-related degenerated changes, and this could be taken as a marked nuclear unrest. So with this, having 2 focus of focal anaplasia with any multiple other areas showing nuclear unrest, we would thought of considering it as a diffuse anaplasia. So now this comes under a high risk category. So we would like to have a discussion on how we go about when we find multiple areas like these in a treated case of Wilms tumor. So this was the final report given. So there was an extrarenal vascular involvement present, so it was stage 2, and 11 lymph nodes sample from this was negative. So in this, because there was focal anaplasia, which fits with the criteria in 2 areas, and nuclear unrest found in other areas, we favored diffuse anaplasia according to the SIOP guidelines. So a little bit about this. So WHO clearly says anaplasia is defined when you have enlarged atypical tripolar mitosis, marked nuclear enlargement at least 3 times the size, and hyperchromasia. And all 3 features have to be present to call some area as anaplasia. So in our case, we had 2 such areas. And focal anaplasia is when you can have, according to SIOP, is when you have 1 or 2 areas with anaplasia, but the rest of the non-Wilms tumor should have no other areas of marked nuclear atypia or unrest. So they have given this as a criteria. So here we have 2 areas with focal anaplasia and the rest with some kind of unrest. So we are considering it as a diffuse anaplasia. So here there are some riders in the criteria that they give, like focal anaplasia. There should be no anaplasia present anywhere else in the tumor, or it should not be present outside the kidney, in the renal vein or any other extrarenal site. And when anaplasia is present, it should be a well-defined focus of 15 mm. That size criteria is also mentioned. In our case, the 2 areas were separate, sampled from different areas and mapped, and they were within the 15 mm criteria also. But since there was background nuclear unrest, we are favoring diffuse anaplasia. And in diffuse anaplasia, they mentioned that when it is present, when any of the criteria does not fit with the focal anaplasia, it becomes a diffuse anaplasia. So we would like certain points of discussion in the pathology here, where when you find focal anaplasia with severe nuclear unrest, can this be considered as a diffuse anaplasia? Then when they don't prescribe any cutoff areas as to what the nuclear unrest must be, whether it is focal or any particular millimeter dimension that they mentioned, that is not specifically given. And what about assessing nuclear unrest in areas of rhabdomyoblastic differentiation? Because those areas can show treatment-related atypia also. However, in us, we found it in both epithelial and stromal components, so we are still favoring anaplasia in this. So these are some points of discussion for other pathologists, which we would like to hear from.
Thank you, Dr. Vidya. That was an excellent histopathological assessment of the tumor. Dr. Kanishka has want to comment on the radical nephrectomy, and then we invite pathologists in the group, because it's not easy to see all these cells, especially when you have found one area of focal anaplasia. It's very rare for our pathologist at least to see so much and then call it a nuclear unrest and then look for diffuse. That is a point of contention, because if it's diffuse, it brings down the survival to 50% compared to 80 to 90% with only focal. Kanishka sir, you're there? Do we have any more pathologists in the team?
I think we have Dr. Swati from KMC Manipal.
Yes, yeah. Hello, sir.
You will like to hear
Hello.
you.
Yeah.
Yeah, Dr. Swati.
Yeah. Usually, I think we use P53, ma'am. I don't know if it is done in this case. Usually it will be mutant pattern, overexpressed in case of when we see an anaplasia. And so was it done in this case?
Yes, ma'am. It was done on IHC and it showed a wild type pattern, but there were areas which had atypical mitosis as well. So they say a cutoff of 70%,
Okay.
which can show the mutation. It's not universal for all cases. So we are awaiting molecular workup still. So in the meantime, we thought we would discuss about these aspects.
Okay, mainly, yeah, we P53, but mainly it is diagnosis by microscopy,
Yes.
morphology. Yeah. So, yeah, I think that's fine. I think with the diagnosis, what they have given.
Yeah, so we'll call it diffuse
Don't
anaplasia.
have much to comment
No,
on.
the question,
Yes.
sorry to intervene, ma'am. The question we wanted from the viewpoint of our medical oncologist and from the surgical team as well was the definition of diffuse anaplasia that we were going through in the guidelines of PSYOP, where the areas which were mentioned as 15, here we have two distinct areas which are 2 to 3 millimeter in size with focal anaplasia and a background of nuclear unrest. There is grading of nuclear unrest as well in certain papers that we found, grade 1, grade 2, grade 3 being given as the criteria for gradation. Hello? Yes, ma'am.
Hey, carry on.
Hello?
We can hear you.
Carry on, we can hear you.
So one of the things that we would want for this child, we wanted to discuss, because we in our own tumor board, we have had this discussion in terms of how a stage 2 tumor with an unfavorable histology like this becomes a candidate for higher chemotherapy, which is more toxic, and for flank radiation as well, when compared to a child who just has a focal anaplasia with a classical triphasic histology. So that was one of the points that we were trying to have a debate on. So this is one of the things that we were trying to sort out for this kid. One of the things that we already mentioned was this child was pre-treated elsewhere by a medical oncologist. So we were actually going to send this kid back for chemotherapy there. So that was one of the criteria that we wanted to be sure about the staging.
So the histopathology is a post-operative biopsy, and it cannot be wrong because you have seen the whole specimen now. So
yes, ma'am.
It will be a diffuse anaplasia. As regards the intensive chemotherapy to be safe, I think you will have to give it. It's open for discussion if anyone wants to deter that. Dr. Dasmeet, what do you feel?
No, I think absolutely on the right track. Chemo and radio is the next thing. So
Shalini?
Shalini's got some.
Dr. Vasudev. We have Dr. Vasudev from KMC Manipal now.
Yeah, Dr. Vasudev.
Why doesn't Dr. Vasu say first?
Yeah, thank you. So I think we come across such scenarios many times where we are not sure whether it is focal, whether it is diffuse, but there is a huge difference between the treatment. So in such scenarios, it's always sometimes better to overtreat, because if you have this child who comes back with the recurrence and you have considered this as focal, then it's very difficult to salvage this particular child. So, when there is a doubt and there is so much of nuclear atypia, yes, the treatment, there is inclusion of radiotherapy and there is upgradation of chemotherapy, but I think it is better to go with considering this as diffuse anaplasia.
In somewhere in the slides you had sent the slides earlier to us, you had mentioned that you could distinguish this separately from post-chemotherapy changes. How do you do that histopathologically?
Yes, ma'am. It's based on the nuclear grading. So in these cases as well, there were some other areas of the rhabdomyoblastic cells which had like a grade 2 to grade 3 nucleus. There was only nuclear enlargement and some kind of degenerative change where the nucleus was becoming smudgy. But in these areas of anaplasia, it is accompanied by atypical mitosis, which is even if you find one, it is abnormal. And we were finding multiple in such a small focus of 2 to 3 mm. And this was accompanied by multinucleation and other
findings
which we find along with anaplasia. So because of mitosis, we could favor two areas as clearly anaplasia. About focal anaplasia, we don't have a doubt. It's the criteria how we upstage it to a high diffuse anaplasia based on nuclear unrest in other areas.
Yeah, I think you're on the right track. Shalini, your comments?
I just wanted to say, if there's a confusion on the pathology, one thing you could do is that send the blocks to Dr. Mukta Ramadwar. I think she has excellent experience with respect to Wilms tumor, and she may be able to help out. But I completely agree with Dr. Vasu that in our scenario in the LMIC setting, it's always better to overtreat rather than undertreat. One more thing is, I heard Dr. Satish saying that you're going to send back to medical oncologist. I think if this child is going to have a high risk chemotherapy regime, I think it's better to send to a pediatric oncologist.
Pediatric. Sorry, I meant to pediatric.
Then it's okay. Then it's okay.
She's under our treatment here, so our pediatric hemato-oncologist is the one treating her. Dr. Julius is online here, and Dr. Dharni as well.
Then no problem. No problem then.
Thank you very much. We now move on to the next case. Nitin, please invite the next speaker.
We now have more than 60 participants at one time, so that's really good. So we thank you so much, Team Rela.
And now just at the closure, I just wanted to invite everybody over to the liver tumor conference that is going to be held just in a couple of weeks from now, 28th and 29th of March. Welcome to Chennai. We would all love to host you. Thank you.
Sure. Thank you. Best wishes.
Thank you. We now invite Dr. Navya Bolu from ESIC Medical College, Sanatnagar, Hyderabad, to do a presentation.
Thank you, sir. Are my slides visible now?
Yes, they are visible.
So good evening, everyone. Today I will be presenting a case. So we had a 4-year-old male child who presented to us with complaints of a right-sided abdominal mass since 1 month. There were no other associated symptoms or urinary tract complaints, no altered bowel habits, and no GI symptoms. The child was otherwise doing well. On clinical examination, the child appeared to be well preserved. And on examination of the abdomen, there was a large 15 into 20 centimeters firm non-tender mass involving the entire right side of the abdomen and crossing the midline. External genitalia of the child was normal, and per rectal examination also showed no abnormal signs. So after the initial investigations, which included the routine blood workup as well as an ultrasound abdomen and pelvis, we proceeded to get a CCT abdomen and pelvis, which showed a large heterogeneous mass that was arising from the lower pole of the right kidney. It was seen in close association with the inferior border of the liver. And it was also shown compressing the IVC. However, the IVC and the renal vein were both free of thrombus, and it showed a large mass effect over the surrounding structures. So these features were consistent with Wilms tumor of the right kidney. As a part of our institutional protocol, we went ahead and did a histopathological diagnosis to help confirm the diagnosis. And we did a FNAC, which again showed, as you can see, round blue cells, which was suggestive of possibility of a Wilms tumor with a predominant blastomal component. An FNAC in our institution is usually done as an adjunct to the diagnosis, and it can be done as a safe method which does not upstage the tumor. And it is a simple and easier method which doesn't involve any sedation and is less pain-free as well, with a quicker response rate. So at this point, our diagnosis was a non-metastatic right Wilms tumor, and in view of the large size of the tumor as well as possible risk of tumor spill during surgery, we decided to give the child neoadjuvant chemotherapy according to the DD4A regimen, which involves vincristine, actinomycin D, and doxorubicin. We plan to give 5 cycles and reassess. So this was our roadmap for the child. We decided to first give 2 cycles of chemotherapy, and following which we inserted a chemo port, and we have administered the remaining cycles. Now, following the initial 5 weeks of neoadjuvant chemotherapy, we reassessed with a CCT abdomen and pelvis again. However, there was no significant reduction in size, nor were there any changes in the features of or the nature of the tumor. So, to confirm our diagnosis and to reassess, we decided to go ahead with a core biopsy along with IHC markers. So, after doing the core needle biopsy, we saw that this was the histopathological picture showing multiple spindle to ovoid cells, and there was a large mitotic activity as well. And this was the report that was given by our institution, which was suggestive of stromal predominant possibility of monophasic Wilms tumor. So just to confirm our diagnosis and to confirm our findings, we decided to get a second opinion at a regional prominent cancer center where we routinely send our specimens. And they had also reported it to be a mesenchymal component of Wilms tumor, and their IHC markers were inconclusive. So at this point, because the child was doing well, and we decided that it was possible for us to go in and do a surgical resection, we proceeded to do a right nephroureterectomy along with lymph node sampling. Intraoperatively, as you can see, the tumor was free from the inferior surface of the liver, and it appeared to be a solid tumor with fairly upfront and easy resectability. This was a tumor which was arising from the lower pole of right kidney. And this is the tumor bed, which we have later marked with titanium clips to help in guiding us for future radiotherapy. So on histopathological examination of the specimen that was sent, this is the cut section, and this showed multiple sheets and nests of spindle cells with spindle and ovoid shaped nuclei that was separated by fascicles. And there is also areas of cystic degeneration which show show areas lined by epithelium. And it was a fairly high mitotic activity that was noted. This was the final report that was given to us by our institution, where they classified it to be an unclassified spindle cell sarcoma with positive IHC staining for vimentin, cyclin D1, CD99, TLE1, and CD34, along with pan-CK, and was negative for BCL2, WT1, S100, desmin, synaptophysin, CD1A, glypican 3, Paxate, and myogenin. So at this point, we were slightly puzzled, and we decided to get, as we did with the core needle biopsy, a second opinion from our local cancer center as well. And this report was given to us almost 2 weeks post-operatively. They have also mentioned it to be a malignant spindle cell tumor that was most probably a clear cell sarcoma of the kidney, which were positive for cyclin D1, CD99, and vimentin on IHC staining. Following this, so at this point, because 2 weeks of the report and the surgery had already passed, we decided to continue with our chemotherapy protocol, and we continue to give the adjuvant chemotherapy as per the roadmap. At this point, we also discussed with a radiologist, and because the reports were differing in terms of the final diagnosis, both Wilms and clear cell sarcoma of the kidney did not have any significant changes with respect to the radiotherapy administration. So we decided to proceed with radiotherapy, where we gave flank radiation for 6 cycles of 10.8 gray. Following this, just to confirm, we also sent it to AIIMS New Delhi for another opinion. And they have also reported it to be features of malignant mesenchymal tumor that was again possibly clear cell sarcoma of the kidney. So at this point, these were the histopathology reports, and these were the IHC stainings that were given to us by all 3 institutions. So in this, what I would like to highlight is BCOR and CD99, which are usually positive for clear cell sarcoma of the kidney. In this case, BCOR was negative in both the reports that we took for second opinion. CD99 was positive in our institutional report. WT1 was negative throughout. Vimentin was positive, and cyclin D1 was positive in both our report as well as the AIIMS report. So after discussing with the parents and giving them the option of either further continuing the chemotherapy as per the guidelines for clear cell sarcoma of the kidney. Taking into consideration that the child was doing well post-operatively, we were able to get away with an R0 resection. We continued, and at this point, the child had almost completed chemotherapy. So the parents and the doctors involved decided that we would finish the chemotherapy as per the Wilms tumor protocol. And since then, he has been healthy and disease-free for the last 9 months. And we have kept him on close follow-up, both with a clinical and radiological follow-up. This is our protocol that we follow. Coming to the discussion, so there has been documented confusion between the diagnosis of a clear cell sarcoma of the kidney, and in those cases where initially it is diagnosed or thought to be a Wilms tumor, 5% of these have actually been reclassified to be clear cell sarcoma of the kidney in literature. And the differences that come up are the following. So Wilms is a more risk-adapted therapy. Clear cell sarcoma, all of them are considered to be high risk. Wilms tumor is usually treated with either a 2 or 3 drug regimen of chemotherapy. Clear cell sarcoma requires a more intensive and multi-drug chemotherapy protocol. The duration coming to Wilms is given for a period of 6 months. For clear cell sarcoma, it is said that according to the latest guidelines of NWTS5, that the duration can be 6 months, but with a more intensive protocol that includes cyclophosphamide and etoposide. The 15-month protocol that was studied and compared to the 6-month protocol shows that the 15-month protocol has better relapse-free survival rates, but coming to overall survival rate, both are similar. Surgery-wise, both have the same surgical protocol. They both require a nephrectomy with lymph node sampling. And in Wilms, selective radiation therapy is done based on the final histopathology report. However, in clear cell sarcoma, routine radiotherapy is recommended to all cases. So as of now, we have come to a point where we have given surgery and radiation for this patient, and this matches with both the Wilms and the clear cell sarcoma. Whether we are doing enough for this patient coming to the chemotherapy protocol, our decision was to stop and keep the child on follow-up after 6 months. So this is something that we wanted to discuss, and whether we should be doing anything more for this child as well. Thank you.
Thank you, Dr. Navya. I think in interest of time, we'll quickly ask Dr. Tejaswini from KMC Manipal to do a similar, I think case presentation is very similar. So then we'll have a quick discussion after. Over to you, Dr. Tejaswini from KMC Manipal.
So can I be made co-host? I'm not able to share my slides.
You were the host.
Yeah, I have been. I don't know. I'm no more the host. I'm not.
Okay.
No, you can.
I'm not able to.
Thank you, Suhashini, for joining.
Thank you.
You can give a comment while she's loading her slides. Yeah, unmute yourself, please.
Make co-host. Yeah.
Sorry.
Yeah. I think I made you co-host. Yeah. Please go ahead.
Yes. Are my slides seen?
Yes. Yeah, please go.
Yeah, good evening, everyone. So there is a similar case to the previous case that was discussed by Dr. Navya. Ours was a 1-year-old, 10-month girl who was born by non-consanguineous marriage, first order by birth. There was no significant family history of any malignancy. She presented with a mass per abdomen since 15 days. She was also noted to have hypertension with a more than 95th centile readings and grade 1 protein energy malnutrition. She had presented with an ultrasound report from outside, which was showing a large, well-defined hypoechoic solid mass lesion, which was involving the upper and middle pole of the left kidney, which was suggestive of Wilms tumor. So as our protocol suggests, we proceeded with CECT abdomen pelvis with thorax. That showed a large heterogeneously enhancing mass, which was arising from the left kidney, with maintained fat planes with the vessels. However, the vessels were getting compressed, IVC and the aorta both. There were multiple lung nodules in bilateral lung. And along with that, there was a collapse of D9 vertebra with enhancing paravertebral soft tissue. So this feature was suggestive of Wilms tumor with lung and bone metastasis. What alerted us was the bone metastasis because it is not very usual in Wilms tumor. So we proceeded with a PET CT, which showed a minimally hypermetabolic left renal mass, multiple soft tissue density nodules in both the lungs, which was suggestive of metastasis, and lytic lesions were there throughout her vertebra, spine of the vertebra, and there were left iliac bone involvement, right frontal lobe bone involvement, left scapula, and right second rib was also involved. So we proceeded with a USG guided through cut biopsy. At our center, the result was a little inconclusive. 3 differentials were given. Mesonephric blastoma was considered the most likely, with least likely to be clear cell sarcoma of the kidney. So we got a second opinion from PGI Chandigarh, and they suggested it is clear cell sarcoma of the kidney. So initially, here we can see the tumor. It's a large tumor which is compressing over the surrounding structures, and also the vessels are getting pushed to the side. However, fat planes were maintained, and on PET CT we can see the uptake of the metastasis. So initially, since we did not have the correct diagnosis, we had started her on the standard PSYOP 2001 protocol, and she was given a DD4A regimen. And once the diagnosis was conclusive of clear cell sarcoma, she was shifted to the higher risk protocol of PSYOP. So 2 cycles of that was given, which included etoposide, carboplatin, ifosfamide, and doxorubicin. So at the end of 6 weeks, we reassessed her with an interval PET CT scan, which showed an interval resolution in the metabolic activity of the primary tumor. However, there was no change in the size. There were all the metastasis had resolved completely except for one left lower lobe lung nodule, which had regressed in size. However, it persisted. So the tumor board decision was to go ahead with left radical nephroureterectomy with lymph node sampling. So in that, intraoperatively, we found a large tumor which was arising from left upper and mid pole, which was about 12 into 10 into 8 centimeter in size, weighing about 1.2 kgs, which was lobulated tumor. It was restricted to the Girota's fascia. The major vessels were splayed, and there was early branching noted of the renal vessels. So they were ligated at polar branches itself. There was minimal perihilar nodal enlargement. However, no iliac nodes were enlarged, and there was no tumor spillage. And lymph nodes that we sampled were para-aortic infrahilar, suprahilar, renal hilum, mesenteric node, and interaortocaval. So our HPE, it's still in provisional report. The provisional report says that it is possibly a clear cell sarcoma of the kidney with a sclerosing pattern. The renal sinus have been found to be involved. There is no renal vein or artery involvement. So it is a stromal predominant intermediate risk tumor, and all margins were negative for the tumor. Para-aortic suprahilar node was positive, so its local staging is 3. In immunohistochemistry is still pending. So we have given her on post-op day 5, we started her on adjuvant chemotherapy, cyclophosphamide for 3 days, and doxorubicin single dose was given. And then week 1 to 4 post-surgery, she will be receiving radiations. She has received only 2 doses, 2 fractions as of now. So the left flank and whole lung irradiation will be done. Left flank will also involve the D9 paravertebral mass. And after that, we will be resuming chemotherapy till week 34. And following that, re-imaging will be done to see further resolution. And in case there is still persistence of the lung nodule, metastatectomy will be then considered. Yeah. Thank you.
Thank you.
Thank you, Tejaswini. That was a nice presentation. So we can now discuss both the cases. So Hashni?
Yeah, good evening, everybody. Thank you for giving us this opportunity. So I think just a couple of points which I think were not, didn't really show up was that while we were waiting for all these reports, almost all the 3 institutes, the pathologist took 2 to 3 weeks to provide us this report. Basically, so what I'm trying to say is none of them were conclusive. And even on insisting they were providing a report of mesenchymal tumor, probably sarcoma. So as to not waste time, we proceeded with whatever we were following. And the good things were that surgically, this was a fairly easy tumor to resect. The lymph nodes were whatever stations we found the lymph nodes we sent, and they were all negative. So it felt, I mean, even the gross, it felt like an R0 resection, and even the pathology report was, it was an R0 resection. So for these reasons, and it was a very well preserved child. So we did involve the pediatric oncologist in the discussion. We don't have a former tumor board in our institute, but we did involve, and the radiation oncologist was from another institute. So all three of us discussed, and this was the plan that we have followed. But somewhere, obviously, we are still keeping our fingers crossed. He has just completed about 6 months, that's 24 weeks, and he's in his first 6 months of follow-up and doing well. So that's what we wanted the discussion, whether we should have done more or whether we should be doing more. We have already presented this, Dr. Shilpa, in a pediatric pathology conference as well, an international. So I think the slides were presented there by our pathologist, and I think a forum of nearly 20 pathologists looked through these slides. And all of them concluded that it is very difficult to comment straight away that this could be a clear cell sarcoma of the kidney.
So what you've done is best in the interest of the baby as you went along, because that is what you thought it was. But now we have to answer a question, what next? So you should look for at least bone metastases that have not been missed, like a bone scan or a PET scan. At least that is the minimum bare that should be done. Its 6 months have already passed, so I don't know whether there's any role of having an aggressive chemotherapy for CCSK now. It's very difficult to say that, but at least get the bone scan done and then keep the child in close follow-up. That's what I would say. It's open, the case is open for discussion. Anybody else wants to say something on this? It's rare to have such a case. No? Usually we get CCSK at least after 4 cycles, you'll come to know. Here you have completed all the chemotherapy and then...
Yes.
And the radiotherapy was given well in time. That was a good thing, I think.
Yes. So we proceeded with everything because we were not getting an answer from any of the, I mean, a clear-cut answer.
Yeah. So brain also, maybe you need to do an MRI. If he's doing fine, it's okay. Yeah, Vasudeva?
Yeah. Dr. Suhasini, in a very good presentation. So I think because you have completed the therapy, I think you just have to have a surveillance plan now, which probably includes getting an MRI brain also. That is what is recommended during the screening process. And if the child has any swellings or bony pains, then keep a close eye on that, and then maybe get an evaluation done. So
in a growing child, it's difficult to evaluate the bony pains because it may be growing pains. So there's no harm in getting a bone scan if it's available.
Or should a baseline PET scan be done? That is something we don't, upfront do it. The initial evaluation involved a CT chest and a CCT of the abdomen and pelvis as far as imaging was concerned. And then 3 monthly, we are following him up with an ultrasound, chest X-ray alternating with the CCT chest and abdomen and chest. So that's what we've been doing. But would there be a role of a PET scan as on date?
It will help you pick up if there are any bony metastases that have been missed. That's it. And have a baseline for future assessment.
Since they are non-Wilms, the last two, I think PET scan is a good way of following up also. And the other point which I wanted to raise was that when you're not very sure about your final diagnosis, how do you prognosticate? And how are you sure whether your chemotherapy is adequate or not, radiotherapy is adequate or not? What kind of hope are you giving? What is the cure rate? So how does one circumvent that problem? So the last
I'm
two
not sure if there
cases
any
are like that.
radiation.
So I want to know what exactly have you done?
Sir, I'm not sure if there are any radiation oncologists on board, but we discussed this in detail with the radiation oncologist from the Basavatarakam Cancer Center. And he was of the opinion that there are almost similar protocols for both the tumors. So we went ahead because at that point, we still didn't have a tissue diagnosis, but we did not want to waste time. So we went ahead with that. And once he finished, even at that point, we still did not get the report from All India Institute. So we continued a couple of cycles. And then by the time the child was so much better, I think if you've seen the picture, he was playing around the ward. So to ask the parents to try to kind of direct them in a direction into a 4-drug regimen, which involves cyclophosphamide, which can sometimes have such dastardly side effects. I was not, I was not sure. So we talked to them, and putting the oncologist and us and the radiation person, we reached this decision. So like I said, we are keeping our fingers crossed. So if somebody has had a similar experience, and we would be happy to learn from the rest of you.
We do have.
I just want to understand. One just question. I just want to understand. So, was the differentiation between Wilms and CCSK, or within CCSK there was a thing that is it a mesenchymal tumor?
Ma'am,
So,
it's a
if there
Wilms
was
and
a
ma'am, it was a
mesenchymal tumor,
Wilms and some other mesenchymal tumor. I wouldn't say CCSK. It was Wilms and some other mesenchymal tumor from all the pathologists. And because we had to insist on the with the pathologist to give us some sort of diagnosis, finally it became multiple question marks and probably clear cell sarcoma. Because as per them, the BCOR is something they see very often, which is positive, but it had come negative in all their IHCs in all the institutes. So they asked for each other's blocks and compared their notes as well. But they were unwilling to give it as a clear cell sarcoma. They only called it mesenchymal tumor, probably sarcoma of the kidney.
We do have radiation oncologist here, Dr. Umesh. Do you want to comment? Your hands up.
Yeah, Dr.
Good
Mish.
evening. Yeah, good evening,
Good
everybody.
evening.
So the thing was that, like, how ma'am spoke about the how sure are we about the radiation? The thing is that the CCSK, the dose does not change with respect to the stage. Stage 1, we don't radiate. Stage 2, 3, and 4, we do give radiation of 10.8 days. But the only thing we ask is the surgeons whether if there any residual disease which they feel when they've operated the patient, or we anyway do a imaging when radiotherapy planning is done. So if there are any residual diseases or suspected residual disease, we boost up to 19.8. So that is the only thing we go about, and that's only without this pathology report, that's how we confirm our radiotherapy plan. And when it comes to metastatic sites, the standard protocol with PET scan size we try to give. In our particular case, what happened was the bone mets was diffuse. And with such bone mets so diffuse, there not be radiation to entire bone mets. And there was complete response with respect to chemotherapy. So what we decided was to just give radiation to the flank and the lung. And the bone mets, we just thought if they are symptomatic, we'll try to give them sometime later. Thank you.
So we look forward to have a good follow-up with your case, Suhasini.
Yes,
And an
yes,
update.
surely we
Best,
will keep you updated, ma'am.
yeah, best wishes. We can move on to the next last case now. Dr.
So
Mish.
Yeah,
just to
I now
answer,
invite Dr. M. Fazal ul Haq from JIPMER to present his case.
Yeah, Dr. Vasudev, you were saying something?
I think I just shared a recent paper.
Yeah,
Dr.
yeah.
Sir had asked about evidence for outcomes, and surprisingly, even in stage 4, this is I've shared in the chat box. The outcome, the event-free survival is as high as 70% using a more intensive chemotherapy regimen. So it's a RN 0321 study which has been published last year.
Yeah, but all these studies are when the tumor is still there. Here, the surgery has been done well, the radiotherapy has been completed, even the chemotherapy has been completed. So now what? When there is no evidence of tumor left
Yeah, yeah.
behind,
No,
now
this is
what?
for CCSKs in
It's a
general.
unique case, yeah. Yeah, Dr. Haq, we can see your slides.
You may have to exit the presenter mode.
Good evening.
Yeah, good evening. We can hear you.
Are my slides visible?
Yes, yes, your slides are visible. You can take it to the slideshow.
Opportunity to present this case. Presenting
Your audio is a little lower side.
audible.
Audible, but it's if you can get nearer to the mic, I think it will be better.
Presented to us with tumor, which was serious in onset and noted by parents. The child had also history of pain, mild pain on and off, which used to get relieved on its medications. So there is no history of fever, altered bowel habit, or weight loss of symptoms. And on examination, the mass was palpable in left hypothalamus, but extending up to the lumbar region. Mass had regular marginal bossulated surface, firm in consistency, moved with respiration, and was bilaterally palpable. As far as the other parameters are considered, the child he was having a BP in the 50 to 90 centile with a EGFR of 126. After baseline investigation, CT abdomen was done. So, large documented solid mass, replacing almost the entire normal renal parenchyma was indistinct and no contrast extravasation from the left kidney was seen. There were multiple enlarged lymph nodes, as you can see here, left dexter, renal, para-aortic, and mesenteric lymph nodes, with the largest of about 30. That child was subjected to CCT thorax. There were multiple enlarged mediastinal chiral lymph nodes, with largest approximately of about 3.1 into 2.9 centimeters. In addition to that, one small 7 cross 5 cross 5 mm irregular enhancing nodule was present in superior lingual segment of the left upper lobe. After this imaging, a differentials of renal lymphoma, renal cell carcinoma, and Wilms tumor was made. The child underwent USG guided biopsy, and after tumor board discussion, the child underwent USG guided biopsy, which showed renal cell carcinoma. Tumor board discussion was done at JIPMER, and we plan to proceed with left radical nephroureterectomy for that child. The child underwent radical nephroureterectomy with left template dissection. Intro findings: there was a large solid mass of approximately 18 cross 16 cross 12 centimeters. Multiple enlarged nodes were there. Renal artery and renal veins, this was completely encased by multiple nodes. Large nodal conglomerate was present, which was extending from SME to the aortic bifurcation. There was no renal vein or IVC thrombosis, or no gross peritoneal disease was noted. These are some of the intraoperative images, as you can see here. The first image, the kidney, which is showing on colonic reflection of the kidney. You can see the kidney and the tumor here with extensive hilar lymph nodes and parietic lymph nodes, which are marked with the asterisks. These nodes were extensive and were encasing the whole of the renal vessels. And due to the proximity to their vessels, it was very challenging to do the dissection. As in the other image, you can see the tumor bed after complete radical nephroureterectomy of the nephroureterectomy. The key vascular structure, the aorta, the IVC and the aorta, you can see they were laid bare open. There was a large para-aortic mass which was completely aorta and the renal, encasing the renal vessels. These two other intraoperative images, you can see the kidney along with ureter can be seen here. Ureter, it was grossly normal of about approximately 2 centimeters of the margin. It appeared to be grossly normal. The histopathological report of this child, it showed it. Histology came out to be renal cell carcinoma. It was T3. The tumor was limited within the Gerotas fascias. This lymph node were positive. There are nests and cystic space of polygonal cells were seen with prominent nuclei. Pale eosinophilic to clear cytoplasm was seen. There was no lymphovascular invasions. As far as the margins were considered, ureteric margin was reported to be positive, but on gross it seemed to be negative. Approximately of 2 centimeter margin was negative. Renal vessel margin was also negative. They examined about 14 lymph nodes, out of which 3 came to be as positive. Immunohistochemistry was done. The tumor cells were positive for PX8, CD10, EMA, Wymintin, and INA1 was retained, which showed aggressive nature of the tumor. CK7, CD19, and HMB45 and Malin A were negative. So, impression of TFP rearranged RCC was made. So, to discuss points to be discussed, which include view of this ureter margin positivity, should completion of uretectomy with cuff or bladder be considered, or as there are extensive mediastinal lymph nodes and lung nodule of 7 mm is also there, should we go for biopsy of that for confirmation of metastasis, or the imaging diagnosis is sufficient? In addition to that, we wanted to discuss is the role of PET CT in this case. And lastly, what should be the management plan for this child? Should we go for systemic therapy, or need your good points on that?
So thank you for your nice presentation, Dr. Faisal. Is Dr. Kumaral here?
Hello.
Hello.
Am I audible?
Yes, yes. We would like to hear your comments before we move on to discussion.
Thank you for giving us this opportunity. Our main problems, the reasons for putting up those intraoperative pictures were that on table it looked like quite a resectable mass, even though it had a lot of nodes, and the entire thing we thought we had taken it out. The pelvis, the upper part of the ureter of about 1 centimeter, there was tumor, but beyond that it appeared to be free of tumor, and we have taken it as low as possible, which is what we usually do in these lesions. So that part of it where the biopsy of the renal, ureteral margin came as a surprise for us. So that is one part of the thing. So if there is a positive margin there, is there any role for completion ureterectomy along with a cuff of bladder, like for a urothelial tumor, which we hardly ever see? We don't see that, almost never. So that is one question that needs to be answered from the surgical point of view. The other points for discussion that we require now are, because this child is probably metastatic, because the chest nodes are large nodes are present, and there are similar nodes in the abdomen have already shown that it is renal tumor. It is stage 4 disease. In the background of stage 4 disease, does this ureteral excision make any sense or no? That is another point. And do we need any biopsy for the chest nodes to identify whether it is metastatic, or is imaging sufficient? If it was Wilms tumor, it would have been totally different, because we have the chemotherapy to help us out in the management and RT. But in this case, we don't have any of those things, except for probably some of the newer systemic therapies that are pretty expensive also, but not easily available also. These are the points that we wanted to discuss.
What about the chemotherapy? When did you start that?
We didn't give any chemotherapy at all, sir. Child has never
Up till
received
now.
chemotherapy up till now, because it was a 14-year-old child which has
Right.
come with a mass abdomen or with extensive nodes on imaging, both thorax as well as abdomen. So these are all classical indications for a biopsy before we start chemotherapy. So age more than 8 years, large nodes which are suggestive either of lymphoma or of renal cell carcinoma of the translocation type. These are all classic indications according to umbrella protocol for a biopsy. So we went ahead with a biopsy, and our pathologists were pretty clear on the biopsy that it is renal cell carcinoma. So we went with upfront surgery. Child has not received any chemotherapy so far.
Now,
After the biopsy report,
RCC, what does the protocol say? Is it upfront surgery, or is it
yes, sir.
34 weeks
RCC,
of
no
34 weeks of
chemotherapy.
chemo with surgery
No, sir.
as an event sometime in between the chemo?
No, sir. We have reviewed the literature and the umbrella protocol. Both of them, as long as the biopsy comes as RCC, once it is biopsy, upfront surgery is this one, because there is no effective chemotherapy for RCC. The only thing that is available are the newer systemic therapies, and there are clear indications for those systemic therapies. One of them would be the metastatic disease.
So how much time has passed since your surgery?
About a month, madam, 3-4 weeks.
Okay. So actually for surgical complete excision, you would ideally need the cuff of bladder to be removed. But now that surgery has already been done, you can go for a PET scan if they can distinguish between active metastatic area there and then post-operative inflammation. If they can distinguish between that and tell you it's clear, then you can go ahead with chemotherapy. For the nodes in the mediastinal, if they're accessible through the bronchoscope, you can go ahead with the biopsy. They will need to be removed if you want to treat the patient. It's an extensive disease, and we will need more discussion on this, I think, with adult urologists who are seeing more of RCC. The RCC which we see, usually we just need to remove the tumor. They are 10 years of age, and such an extensive one, it's difficult to treat.
The pathology wise, this is also a translocation related, appears to be a trans. We have not done the genetic studies, which would be what we see in pediatric adolescent RCC rather than an adult RCC. Our med oncology discussed it with their counterparts who are looking after the RCC in adults, and they were suggesting to start one of the this one, but it is pretty expensive, and they have asked for some help for this one from
Immunotherapy?
PM's
To start immunotherapy?
Immunotherapy.
Yeah.
So that is what is our local this one. But I thought since we have an opportunity here to discuss.
And how is the prognosis after immunotherapy if the nodes and everything responds to it?
Not much is discussed, madam. It is just like a trial. It is not not well discussed. This particular type of.
And what is the estimated cost if in private?
It's around 30 to 40,000 rupees per this one per month, I think, and it needs to go on for a few months. That is what they are. He was telling it needs to be continued for quite some time now. This one, but again, there are some. They have these equivalents which are for the immunotherapy, which probably may come down cheaper. But that we are exploring the possibility. Parents are not able to afford it right off, so we are trying to get it through one of these NGOs.
Yeah, some can kids or someone. Have you got a PET scan done?
No, not yet. That was one of the points for discussion, whether PET scan would help so close to the surgery. That was one of the things.
So 6 weeks is the waiting time. You've already crossed 4 weeks.
4 weeks.
So you can go ahead, with the PET scan. And if it is possible to go back in surgically for any lesion that you find, if it's positive, if laparoscopy can be tried. If
laparoscopy should be possible for the ureter, not
for the ureter and
because the ureter looked absolutely clinically on table. The ureter looked absolutely where we dissected and put a clip there, tie actually. It looked quite okay. So taking it out with a cuff of bladder shouldn't be an issue. Mediastinum is quite extensive disease. We have just put 2 slides, but it is quite extensive disease. It will be a major undertaking if the parents accept that we can go in. But I don't know how much will be the outcome. How much will it help in the long-term outcome?
Any role of radiotherapy, Dr. Umesh?
Hello. No radiotherapy in RCC. It's a radio-resistant tumor. So it doesn't. We wouldn't do radiation in this.
That was the impression of our radiotherapists also, that there is no role for radiotherapy.
Difficult case. Immunotherapy is quite expensive and unknown prognosis.
Outcomes and prognosis.
What does the family feel about it?
Child is quite, compared to what he came with, child is quite happy running around. So they are not really this one, but we have explained to them. They understand, the father especially understands it, but he was hoping that the immunotherapy would help the child. We are keeping the child on close follow-up.
So I think you should go ahead with PET scan and try immunotherapy. Try to get some funds raised for him. In AIMS also, if you send, the chemotherapy has to be provided by Can Kids or the parents buy. The hospital does not give the expensive chemotherapies. So that's an issue. It's just that the administration and admission will be free. But and any other schemes that can help, Ayushman Bharat or some other schemes?
Actually, PM's fund they have applied, but that usually takes about 2 to 3 months. We are trying to get a local NGO to help out in the interim for that 2-3 months. They are looking into it.
I think we keep this child on the follow-up, and meanwhile we can speak to our colleagues and get back to you on this. If anyone has anything else to add, Shalini?
I just want to say that
Dr. Vibha?
I think surgery is the best option. Yeah, surgery is the best option for RCC. I think whatever can be removed should be removed.
Yeah, so do a PET scan, at least the lower part, whatever you find, you remove it. Because in RCC they say if you remove the primary, the secondaries can melt away.
If you
Because I have
remove
got many colleagues.
whatever can be removed, that's the best.
Yeah, that's best. The mediastinal nodes are not removable.
To the tune of doing metastectomy, if the metastases are numbered and well within the reach, I mean, being a non-surgeon, it's easier for me to say, but if it can be removed, that would be the best chance for the child, more than even immunotherapy.
So let's get the PET scan and then you come back to us.
Then we'll
yeah,
sure.
we can
do
all,
that.
you get the PET scan, we can again come back here.
Disease is remaining. Yes, look at whatever disease is remaining and if it can be resected.
Yeah, that will be the best.
Even a second look surgery is justified. Even a second look surgery is justified in many of these children. I mean, you go back after the diagnosis is done, which is absolutely okay.
Provided you are able to remove the entire tumor from the body.
Absolutely,
The mets
absolutely.
also, the
It
primary
should be.
also.
Yeah.
Then surgery is
Yes.
definitely
Exactly.
a very good option.
Yes.
So
In
we'll
fact,
have a look at the
in
PET scan
RCT
once.
is the only option. Yeah. And if this child has the translocation positive, we need to do the molecular workup. So then that makes him a good prognosis. So I think we should really try.
Give him all
If
the
they
chance.
have the mutation, I think there is some mutation. I forget exact name.
Yes,
Something
madam.
with X. If the RCT mutation is positive, then he has a good chance.
We will definitely get back to you after all this, madam. Hopefully, we will try and convince the parents for more extensive surgery on this one. I have also, since clinically it didn't look ureter, also I have asked them to review the slides as well as section again, because if that was
Margin.
that margin was from a different part where it was higher up where the ureter was sampled. I'm sure they should have done it from below, but
Yeah,
since
you
there
can
was
have a
some
look at
doubt
that.
in this one that I've requested, if that also, then we'll only have to concentrate on the thorax, because the abdomen otherwise was pretty clean. Pictures we have shown.
Thank you so much. I thank all
Thank
of
you very much, madam.
Thank you. I thank all of you for attending. It's a really good discussion and look forward to seeing you again. Thank you, Dasmit sir. Thank you, Navya, Dr. Umesh, Dr. Nitin. Thank you.
Thank you, ma'am.
Thank you, Dr. Rajendra. Bye. Thank you.
Thank
Bye.
you. Good night.
Bye.
Thank you,
Bye-bye.
Sharon. Bye.